Not really. I've just noticed a lot of the drugs are used for multiple issues with the heart. Like a lot of them are used for heart failure and dysrhythmias and hypertension. So it's kind of hard trying to organize that
Yeah,
information.
I can see, that's a typical thing with students, even at graduate level. I just taught the nurse practitioners the cardiovascular section, and it just seems to kind of go in circles sometimes because you're using this drug for that and that, then for something else. So when you're looking at indications, you'll want to include those on your drug card.
Hmm.
If a beta blocker is used for angina and it's used for hypertension, you just want to make a note of that as an indication. But you'll want to really focus on the mechanism of action and why. And when you're studying cardiovascular system, what you really want to do is understand your patho and understand how the drugs work on the patho. And once you have that, then you can kind of apply it to different problems. It
Okay.
makes sense. Well, in heart failure, if something reduces preload or afterload, then it's going to help heart failure because it's a pump and those type of things that go with heart failure. The fluid overload, pumping against pressure, all of those things. So it's really, I think there's not a lot of drugs. If you've noticed, there's not tons of drugs.
No,
But
no. A lot of them are the same classes.
yeah, you use them over and over again. So I'm going to, let me see if I can share something different with you. Stop sharing. And then I'm going to go share application, Microsoft Word. Okay. Now you should see what I'm drafting for the blueprint, what we're editing. We've already, done it, but we're working on it, making sure that it's right and all that. But you can kind of see on the blueprint, when you get down here, diuretic class, we're probably, you'll probably see beta blockers in multiple chapters,
Hmm.
but we try to, like here it is in heart failure, and we did not put it in the chapter 25. So you'll see that, we're trying to, not have you study two different prototype beta blockers because they're pretty much, you're going to, atenolol and metoprolol are going to act much the same. It may be here, yeah, it is in angina and in heart failure. But if you look at, generally speaking, the number of drugs in these categories in these chapters are pretty small. And
Hmm.
you've noticed that on the blueprint and in the chapter, you get a lot of information, general information about diseases, the patho, and lifestyle, drug monitoring. So it isn't the course isn't really drugs 101. It's pharmacology, and that includes how medications work on the body and why and the patho. And so it's really an introduction. It's an introduction to pharmacology, and you'll continue to learn once you get into the program. So as
So,
far, go ahead.
sorry, on the blueprint, like for instance, on chapter 23,
Uh huh.
how it shows kidney function, renal failure. So, like you said, the chapter talks about the patho as well. We can, I guess, count on there being questions on that test that are related specifically to patho and not just drug use.
There will be questions on the test about kidney function. How kidneys function. I can't tell you what questions are on the test because that's what faculty want is we want. The goal is for students to have a broad knowledge, a broad basis to move forward to learn. And for this reason, we encourage students to do all their readings, and then after they do their readings, to focus. And when you go, these little topics right here, if you see that, they match the book, the little sections. So this is focused readings and to look at it, but I can't tell you, oh, you're going to have to know what lab test is you check for lipids or things like that. But I can just tell you, you need to look at drug monitoring, and these are good things to know for practice. You know, what we want to do is train you to be an excellent nurse, but also we want to help you to be successful and focus in the course that gets you there. So it's a balance. It's a balance. So to answer your question, there will be, like there was on the last one, sometimes you have to know something about hypertension. What is hypertension? What are the normal values for blood pressure? And because that's when you're monitoring outcomes for patients, if you have a patient with a blood pressure of 125/80, are you going to be concerned? Those are things that a safe nurse knows, not just that hypertension, you know, an ACE inhibitor has an indication for hypertension and an adverse effect is a chronic cough. You see what I mean?
That makes sense.
Pardon?
That makes sense.
Is it making sense? So when personally, when I do a blueprint, I go through the chapter and I look at the headings for the sections. And so I don't look at the test and say, oh, there's a question about plaques in the arteries and how it affects blood flow, which that's off the top of my head. I don't look at the test and say, oh, I'm going to say there's one, this is question 1, this is question 2, this is question 3. I say these are the general topics, because you may have a question on a statin that requires you to know something about LDL.
Right.
See, so it's not, you can't say, well, if there's 5 or 6 questions, I'm going to count these little ones, and I know there's going to be one question from each section, because there may be, like I said, a question on statin that requires knowledge about lifestyle modifications, but there's no question specifically on lifestyle modifications. So, you know, it requires you to know those things to be able to just have the background that you need to make the right answer choices. You know, because sometimes, if you look at a question, sometimes it's asking for at least 2 pieces of knowledge.
Mm-hmm.
You know, if you don't know exactly that, if you didn't read exactly that sentence and don't know exactly that information, but you know other stuff, then it sometimes leads you to the correct answer because you know the other ones are wrong.
Right.
So, yeah. So it's not easy, but we try to make the test pretty straightforward. That's our goal, is to not make it tricky, you know, to test on the things that you really are good to know, you know, that make you a better nurse and learn. So have you done the reviews yet?
I have not. I actually bought a workbook that was offered through the bookstore.
Yes.
And it has review questions and stuff, so I use that quite a bit. I'll like read through the whole unit, and then I go back and try to review with those questions and see what I need to, you know, touch on more.
Good. I think we've had some good feedback on that recommended resource for that supplement. So that's good. Did you feel like it helped you on the last test?
It does help. I really like to practice with the NCLEX style questions because those are harder for me. I try to focus on those, especially at the end of the chapters. They have NCLEX review questions and critical thinking questions, and those quite a bit also.
Good. And so if you go into exam 3, what class am I now? I'm in the wrong class. Okay. I knew y'all weren't studying infectious disease. Okay, here we go. Pharmacology. Sorry about that. Okay. Units and lessons. So if you go in right here to exam 3, which the blueprint will go up tomorrow,
Okay.
It says right here, you will see a grade recorded in the grade center for these reviews, but the grade is not averaged into your course average. It's not going to be averaged into your course grade. After exam 3 is scored, students who have successfully completed these reviews will have additional points added to their exam 3 final scores.
Oh, okay.
So I highly suggest that you do that. And, yeah, and they're going to take some time. They're not, they're not just quick things. That you should get credit for this because it's a lot of work.
Yeah.
So I would, kind of suggest that you get into there. And have you done any of those type of reviews? Did you do them last time?
I did, yes. I did those last time.
Okay.
I haven't done any yet. I was kind of trying to save them till the end to, see what I really got a good grasp on.
Yeah. Well, it sounds like you have a, kind of a method to your studies, so that's good.
Madness.
Yeah. So that we can go over a couple of them if you want to.
Sure.
Yeah, and so you can write them down, and they're, it's hard to do these things as far as it's from a student perspective because I go in and do them too to test them out and whatnot, and it's not easy. And I always hate it when faculty, have a fill in the blank and they want you to think of a single word and no other word works. I always hate that, but it's. On the other hand, as a teacher, it's really hard to produce review materials that don't involve something like that. Otherwise we'd have to come up with, 100 multiple choice questions, and that is hard. We can't, that, and then because we take a lot of time writing questions. It's not easy to do. So if this one is niacin will cause flushing, which is worse with what? Fluids. So we're going to look at the hint here, and it says, I think I'm in the, let me get to this point so it goes the whole screen. Can you see my screen okay now?
Yeah.
Okay, so quiz fruit, so, it mixed them up. So
Okay.
Go ahead.
I was just wondering about niacin. That one isn't one of the prototypes?
It is, if you look at the textbook, it is it is a section in there. It's a section in it's a class. So you can see here that the niacin is actually the class. If I'm not mistaken, you can look it up. So there's really no drugs. Let me go get my book. Hold on.
Okay.
I usually pull up my electronic version when I'm at home, but I don't want to change my screen. So let me open up my actual physical text.
I found it in chapter 22. It's on page 293 for me.
Okay. So is it a class of drug? Yeah, it's talking about the different classes, the different drugs used. So niacin, there's no prototype. It's actually more of a nutritional supplement, and so that is on the list. So when you get the blue book, you'll know. Oh, I need to go to page 293 and read about niacin.
Mhm.
Okay, because that's a good one to. People take that. It's over the counter, and you will have patients that are on it, and there's also medications that are prescribed that are niacin. Long acting and things like that. So but you'll want to know that in general because your patients will be, taking it.
Mm.
Okay. So let's get back to this. Lopid should be administered with blank to decrease GI stress. So, whenever you see something administered with in GI distress, you're thinking of the stomach. So it's easy to think through that one. Because I'm going to think, oh, should it be administered with food or milk or an antacid? You know, I'm going to think of something that makes your stomach feel better, right? So I'm going to look at, and so there's the hint, and it's food. Anytime there's something about a medication should be administered with or in association with, it's either with a meal or without a meal. You can always bet it has something to do with whether they're eating or not eating. So, for several years, research has demonstrated a correlation between low-density lipoprotein and coronary blank disease. So, low-density lipoproteins are the bad proteins. Those are the ones that clog up the arteries. So you probably know that if I look at the hint there, it's going to be coronary artery disease. I think, yeah. And then here's a little link to a YouTube presentation that you can also look at. The most important thing for nurses to assess in patients taking a statin is complaints of muscle pain, tenderness, and weakness, as this could indicate a type of myopathy known as, and then this is a really long word, but rhabdomyolysis will actually cause renal failure. What happens is the muscles break down and they get into the bloodstream and they lyse. What they call lyse means that they break up. Like if you have a red cell that lyses, that means it exploded and now it's in the blood. The contents of the blood cell are in the blood. So it hits the kidneys and it's very serious. Let's see, rhabdomyolysis. Did I spell it right? No, myolysis. I can't spell while I'm talking. Let me start over. Let's see. It's probably spelled wrong, but it's close. Rhabdomyolysis. We can look it up. Okay, so high density lipoproteins. Think of high density as a good grade. That's a good lipoprotein. It actually cleans the blood. So the low density ones are bad. It's like a low score on the test. A high score is a good thing. So high density lipoproteins are good. And I'm not quite sure about the answer to that one. Let me see. I have to. I think it's okay. Let's see. What do you think?
I think it's true.
Okay. I do too, but sometimes I have to look up the answers too, even though I wrote them. Because if there's one word wrong, then I'm in trouble, right? Okay, let's see. High density lipoproteins is away from the body tissues and back to the liver. Yeah, that statement's correct. Okay. Take one blank tablet 30 minutes prior to niacin. So you see niacin is pretty important because people take it. Okay, can reduce flushing. And this is that kind of when they say a flushing, they mean somebody gets kind of red, like they've gotten embarrassed, but they get kind of sweaty. And then here's the hint. So you can probably see the answer there, right?
Yes.
Spelled out. Okay, essential to building plasma. Okay, this is a matching thing. And then this one is kind of weird because it has cholesterol as both an answer and a question. Right? So that makes it kind of hard. So triglycerides. Let's go with B. Major form of fat in the body. And these are probably just a little bit of a review, for the importance of cholesterol. Sometimes people think, oh, all cholesterol is bad, but people need cholesterol in their diet. They need to eat fats. And we make our own fat. Sometimes you have people with super high cholesterol, and you think, oh my God, what are they eating? Well, no, people make their own. You know, you can have people who have a relatively good diet, and because of uh, genetics, they produce a lot of cholesterol. And it doesn't mean they're fat or they eat poorly or they're not obese, things like that. They just have a lot of cholesterol. So our body makes cholesterol because we need cholesterol. So triglycerides are a major form of fat. Phospholipids, let's see, essential to building plasma membranes. Cholesterol is a building block for estrogen and testosterone. And then synthesized by the liver from other chemicals. What do we have left? Do we have C? No? Yep, C, synthesized. Cholesterol is synthesized, or no, we already used that one. Yep, that's right. Synthesized by the liver from other chemicals. So even in people who don't eat a lot of cholesterol, everybody is making cholesterol in their liver. Lipid-reducing diet should include salts, fat-soluble or soluble fiber. And the hint shows a lot of fiber. People who take Metamucil, it's been shown that Metamucil will actually reduce cholesterol. There's a lot of people who can't tolerate statins, and statins are the mainstay of treatment for cholesterol. There's a lot of people that can't tolerate statins because they get the muscle pain, like it doesn't go all the way to rhabdomyolysis, but they get the muscle aches and they get different side effects and they just can't take it. We had one lady whose legs were twitching. Her muscles in her legs were twitching. We had another lady who her thumbs would get all her tendonitis in her thumbs. It's weird, but then other people act like it's nothing, no big deal. So the answer to this form is warm fluids. The answer to this one is warm. Okay, elevated creatinine phosphokinase, CPK level should indicate blank. If this is suspected, hold the statin. So I think this is probably rhabdo again. Oh, myolysis. Myopathy, maybe myopathy. Yeah.
Yeah, I think it's myopathy.
Yeah. So these are are you seeing these sentences in the book?
Let me see.
Well, you don't have to look, but you probably will see exactly these sentences in the book or something very close.
Yeah, something very close to it.
Okay. And then this one is other drugs, and this is talking about other drugs must be more than cholestyramine. Now, cholestyramine, is that a prototype drug?
It is.
It's not going to be on our list, and this is something that they drink it. Cholestyramine they drink in water, and it gets in the intestine and it binds the bile, which holds the cholesterol. That's kind of a real easy way to look at it. But you drink it and it gets in your intestine and it binds the cholesterol in your intestine, and then you poop it out. You know, they excrete it. And so when you're taking other drugs with this, it may bind those drugs. So other drugs must be administered 2 hours before or 4 hours after the drug. And people will use this also in patients, you know, for other reasons, but it's used for cholesterol too. So we can check our answers. Let me see if I got any of them right. So when I check my answers, then it shows me everything. Okay, it shows me everything here. So I didn't answer that one. And then I spelled that one wrong. So there was a Y right here, rhabdomyolysis. So watch me have spelled it wrong in this, in the key. That's a long word. So okay. All right. So that's what you'll see on the stat page, and then you can match those up. Those are just another one of those kind of little things to know your cholesterol type of thing. Okay, so diuretics and renal failure. So now we're going on to chapter 23, and I'm just kind of, going over some kind of highlights and, but feel free to jump in if you want to. Renal failure is staged. They stage kidney function, and people will have chronic kidney disease, and they'll also have acute renal failure. So people with chronic kidney disease are slowly failing, and they go from stage 1 at the top, and you aren't going to be asked questions on this, but just so you know, they start at stage 1, and then they go all the way down to end-stage renal disease, end-stage kidney disease, and that is when they go on dialysis. And so but then you can have somebody who has acute renal failure for an acute reason, which you'll learn about later when you're in the program. But there's a difference between acute and chronic, and then there's a lot that goes with it because you're working with fluid. So when somebody has renal failure and their kidneys aren't excreting fluid like they should be, then you get fluid overload. And then that affects the heart, the pumping, all that stuff goes on. So one thing leads to another, and renal failure is a reason for heart failure. And it's also a reason for hypertension, secondary hypertension. If you have renal failure, you're going to have hypertension because you have too much fluid in your blood. So they try to fix the kidneys, they try to help the kidneys, and then it helps the hypertension. Okay, so let's look and see what these say here. Elderly patients should take diuretics early in the blank to avoid nocturia. Nocturia is nighttime urination. So what would you guess to be that answer?
Early in the day.
Yeah, or morning. We really, they can take it. Sometimes we'll have patients on Lasix, which is a diuretic. We'll have them on that twice a day. And usually we would give it in the morning and at noon. We will wait. Lasix usually lasts about 6 hours, so maybe 8 and 2. But we want to try to get that, all the diuresis that's going to happen from that medication in before nighttime. Because if you have an old person and they're getting up at night and they don't have real good vision, and let's say they wake up and they have to go to the bathroom really bad, and they get up and they don't make it to the restroom, then they've got a wet floor and they may slip and fall in it. Mm-hmm. Or their light may not be on, they may trip and fall. So anytime you have an older person who has to get up at night to use the restroom, you have to have precautions, because we're talking about frail kind of older people. Say so furosemide, let's see, that's spelled incorrectly. And sometimes it's difficult to get these, find all the little errors. So furosemide or Lasix is a loop diuretic. Oh, that's right, yeah. It's a loop diuretic because it acts by preventing the reabsorption of sodium in the loop of Henle. So there's 2 blanks, but they're both the same answer. And Lasix is so common. I mean, you will see this in a lot of people, and it's like first line for heart failure. Well, anytime we have somebody with symptoms for heart failure, shortness of breath, edema, weight gain from water, if they gain more than a couple pounds in a day, things like that, they're on Lasix. And so this will be something that you'll see patients on all the time. Okay? And so it's important to know that drug, and especially when do you start the program?
I start in the fall.
Okay, so when you get into the nursing home, you'll be usually in the first semester you're going to be in long-term acute care or long-term care, and that's where you'll give all your, you'll start giving insulin, you'll give a lot of medications, you'll look a lot of meds up, so don't throw your book away, don't sell it back. Okay, and so match the items. This is just a patho to say, what works where, and you can look those up. And this one is any amount of protein in the blank is considered abnormal. So I just said the answer urine. Yeah, if you have any protein, when we do a urinalysis, we'll have them, I'm sure most people are familiar with that, they put urine in a cup, And then we do this dipstick. We dip a stick in there and we pull it out, and it has a bunch of colors on it. And then one of them measures protein. So we don't want any protein in the urine. And so I think that that is the correct, urine is the correct answer there. And there's a picture of the dipstick. See? So you get lots of information. I should have been clicking on the hints earlier to make it more fun. Okay, diuretics are indicated for the treatment of renal failure blank and for the removal of edema fluid. So diuretics are indicated for the treatment. This is the indications for diuretics. Why do we use them? So are they used for hypertension or hypotension? So that's pretty easy, right? If we have somebody with hypotension, don't give their diuretic. If their blood pressure is less than 100, if their blood pressure is abnormal and it's too low, do not give the diuretic. Do not give the hypertension medicine. Think about it. You know, and when I say think about it, I'm not saying like you need to think about it. I'm saying we need to critically think as nurses and say, why am I giving this? I have a beta blocker and the heart rate is 55 and it lowers the heart rate. Do I give it? You know, those are things that we have to, when we say critical thinking, what we need for nurses to, what nurses have to do is to think before they act. Even though there's an order for something, we don't just say, okay, I'm going to give this. We think about it. If we check the blood sugar and the blood sugar is at 65 and we have an order to give 5 units of insulin, we're going to think about that before we do it. And we're probably going to call the doctor or the prescriber and talk to them about it. So you're going to hear critical thinking a lot, and that just means the why. Why am I doing this? Should I be doing this? And, you know, there's a common, I just had a case at the nursing home just Saturday. A nurse, they received something to discontinue a medication from the pharmacist, the suggestion to discontinue medication. And the director of nursing is an RN, and she told the LVN to go ahead and write the order in the doctor's name to discontinue this med. And it shouldn't have been discontinued. And the LVN, I said, why did you discontinue it? She told me why, and I said, well, you understand that, you know, you have to think through these things, and if it doesn't make sense to you. She said, well, yeah, because his blood pressure was high. I'm like, okay, well, you have to say to people, even doctors, even your bosses, why? Why am I doing this? So that, you know, because then you protect yourself and you protect your patients is the main thing. Okay, wheezes are commonly authenticated in pulmonary blank, which occur in renal failure and high fluid retention. So wheezes are, and that has to do with when you have fluid buildup. And so the answer there is edema. Edema is fluid. And so when you listen to the lungs and you hear fluid in the lungs, it can be heard as a wheeze or a crackle. And so we would want to, I think that in the book there's some stuff on pulmonary edema. So that was kind of focusing, you know, telling you to read that a little bit. Mm-hmm. Patients receiving thiazide diuretics, which we call HCTZ, hydrochlorothiazide is the main one, should check their weight daily and report a weight gain. And so those are people that are have heart failure. Let's see if there's no pictures. The plain blank is the blood fluid for the patient to consume while receiving diuretic therapy. I'm probably going to say water.
Yeah, that's what I thought.
Yeah. So we don't want them to, you know, be drinking electrolytes when they're on diuretic therapy, because it's going to, you know, we're trying to get their sodium. That a lot of times the water, the RAS system is causing them to retain aldosterone and, you know, and causing them to retain sodium. So we don't, and that holds the fluid. Remember that the fluid goes wherever the salt is. And you can think of salts as electrolytes because they're heavier. And I always like to say salt sucks. So remember, wherever your salt is, there is the fluid. If your salt is going out in the urine, so is the water. If your salt is staying in the body, there's the water. Wherever the salt is, because salt sucks water. Okay, so you can just think of those principles when you, and then there's going to be some questions you can just think your way through. Concurrent use of spironolactone, aldactone, and ACE inhibitors such as lisinopril may dispose the patient to, and then that is a problem with potassium. Spironolactone is a potassium-sparing diuretic, and an ACE inhibitor also spares potassium. So the hint is hyperkalemia or hyperkalemia.
Hyper.
So those two used together can result in hyperkalemia. And you know that when they do the death penalty, when somebody gets the death penalty, one of the drugs that they get is potassium.
Yeah, I read that. I don't know if it was in the textbook or something I was reading online, but I read that and thought that was kind of crazy.
Yeah. So it's, you know, when you think of somebody having high potassium or even low potassium, think of the heart. Always think of the heart. Heart rhythm, dysrhythmias, arrhythmia, which no heartbeat. And, you know, that's, sometimes you'll see like in these lists of electrolyte symptoms of hypo and hyper, you'll just see all these crazy symptoms, and it looks like everything in the book. Well, how am I going to know what to focus on? And in one of my postings I put, if it's sodium, think brain function. If it's calcium, think muscle function. And if it's potassium, think of the heart and heart function. So they do a lot of other stuff, but at the same time, any question you see on your boards or in class, or the main issue in clinical practice with patients who have these imbalances are those systems. Even though you may have a patient with a hypokalemia that has muscle cramps, but that's not your major concern. You know, yeah, it is to the patient, it hurts, but you're going to go check the heart rhythm. Check the heart rhythm is your priority, and then if they have a hypokalemia with muscle cramps or GI cramps, then that's something that we can, you know, fix, but it's not life-threatening. So sodium will cause a coma. They'll go into a coma and die. So, but also it causes other things that are very similar to the other electrolyte problems. So I always hate that because it just, you know, I'm just like, what? I don't know. I can't remember all that, and neither can most people can't. So, okay, so put the items in the order of patients with renal failure. Okay, so am I in the right one? Okay, reducing medication doses. So people with renal failure, we need to know if they're nephrotoxic. Now, nephrotoxic sounds really bad, right? It seems like if I give it, that nephro is kidney, toxic is, you know, going to hurt it. So that's a big one. Reducing medication dosage is a big thing with renal failure, because a lot of drugs are cleared by the kidney, right? Chief organ of elimination, or you know, that's the kidney. So if they can't eliminate it, then the drug dosage, the drug builds up in the blood. Order of importance with renal failure: measure the patient's fluid intake and output. So that's a response. People that don't have an urinary output are going to be, you know, if people in renal failure, you want to know that. There's a minimum amount that you want to see in an 8-hour period. And I don't remember, I haven't been in the hospital in a while, so you'll have to learn that, but you'll want to monitor. I think it might be like 200. I don't remember what the mLs are, but you won't need to know that for this class. And knowing which drugs will increase fluid retention. So I don't really know if I were going to guess, I would say this is probably number 1, nephrotoxic, and then I'm going to probably go with 2, because both of those things could really hurt the patient, right? Because if you get a buildup of digoxin, their heart rate could really slow. And then, so we'll see. We'll see. But now you understand that this is just trying to help you think about renal failure.
Yeah.
And so each one of these things have retakes. So if you're, a passing score on this is an 80%. So, you can do it as many times as you want to get those extra points.
Whenever I go in to take these reviews, do I have to sit down and do the whole first unit at one time?
No.
No.
No, you can go back in and update it and continue it. Okay? And if you have any trouble, let me know. But it should let you just pick up where you left off.
Okay.
Okay, orange juice and bananas are high in potassium. And there's the hint. And then we can go through those a little bit more. Fluid balance and electrolytes. That is the one with the, I think this is the one that has the blood products in it, right? It has the albumin and then the solutions. The solutions. Okay.
Yeah, it has the hyper, the hypo, and isotonic.
Yeah. And this is where your salt sucks is going to be so important to remember. Okay? And think about, I had a presentation. Let me see. Stop sharing. And now I'm going to go to the whiteboard. And let's see if I can do something here. Okay, so normal saline in the body. This is the normal ratio of salt to water in the body is 9%. And we call that normal saline. And so we have normal saline solution, which matches the body, the normal body ratio of salt to water. And that's normal saline. Okay, so let's say that we have 0.9% is less than 1%, right? It's a low amount. So if we give a patient a hypertonic, we call that hypertonic, and it's a greater than normal ratios of salt to water. So now inside of your vessel, this is your vessel, you're going to have extra little salts, a lot more than you had before. And so what is this going to do? What is this salt inside the vessel going to do?
It pulls the water into the space.
Right. So that seems so simple, right? But that's a lot of what you need to know. If you have more salt inside of the vessel, it's going to pull water from the tissues and from the extravascular areas, whether it be, the cells, the muscles, all the areas that are not inside the vessel. And so when you get more water inside of the vessel, then it's going to increase this pressure against the walls of the vessels. I wish this wasn't so thick. And so what is that going to result in?
That increases the osmotic pressure?
Yeah, and it's going to reduce blood, it's going to increase blood pressure. When you have more water inside of the vessels, it pushes against the walls, and that's pressure. So that will increase your blood pressure. So you have someone come into the emergency room and they are dehydrated because they have had diarrhea or some sort of a problem with their kidneys that has caused them to excrete tons of sodium and water. They got rid of the sodium and the water at the same time. Now they have hyponatremia. Let me put that up here. Now they have hyponatremia. So they need salt inside of their vessel. And they're going to have low blood pressure because they lost fluid. So we'll give them a hypertonic solution in order to draw the fluid out of their interstitial places, out of their extravascular places into their vessel, to increase their blood pressure and then also increase their sodium levels, because very low sodium can cause a coma. You know, remember, sodium is neuro. And when you're looking at these salt solutions, you know, these IV solutions, you're going to have the hypotonic, which is let me see if this will work, 0.45. So if you know percentages, you know that that is less than normal saline, the normal ratio. That's hypotonic. So if, let's say that you did that, and now we're going to, it's not going to erase, is it? I thought it might erase. No. Okay, so we're going to take out these particles here. We're going to give them a solution that has more water than salt. And now inside of their vessels, they have less salt than their tissues, right? The balance here between the tissues and the vessel is now changed. Now outside, they have more salt than they have inside the vessel. They got more out here, and so now the water is going to follow the salt. Now it's leaving the vessel and going into the tissues. And then this will lower the sodium levels inside the vessel, and it will increase the water outside of the vessel. So that's pretty much what you need to know about solutions. If you know this, and then later on you add on the solution like D5W, which has got sugar in it, or lactated ringers, you ask, is that a hypertonic or a hypotonic solution? And then you'll know if it's going to be adding salt to the vessel, or it's going to be decreasing the salt and causing fluids to go to the tissues. So, but for this course, really what you need to understand are those saline solutions, hypertonic, hypotonic, and also, you know, understand what happens, you know, to the salt level in the blood when you lose fluids. Let's say that somebody is exercising too much, and they are just drinking plain water. So they're losing a lot of sodium, and then so inside their blood they're going to have they may have too little sodium because they're losing sodium, and they may also get dehydrated because they're losing fluid also with the salts. And so think about somebody that's dehydrated from exercising too much. What would we want to do? We would probably give them, in actuality, if they're able to drink, we would give them a drink with some sodium in it, like a Gatorade or some hypertonic solution, oral solution, to drink, and lots of fluid, so that they get more salt in their blood, and the water's going to their blood from their gut because they have salt in their blood. Okay, so not trying to confuse you, but just to think about it, if they're unconscious, in reality, we often give normal saline, because giving hypertonic solutions it has to be pretty radical to do that. Because if you can replace just this with normal saline and get them hydrated a little bit, or oftentimes this will balance out itself, you know, rather than giving them a hypertonic. But you might do that, but it would be more of a critical situation. So if you have someone just comes in with mild dehydration, but they're vomiting or something, you'll probably give them normal saline. So
with the hypotonic solution,
hyper or hypo?
Hypo. It distributes the water. It leaves the intravascular space, and goes outside to the tissues.
Yes.
So does that decrease the salt in the intravascular space?
Yes, it will. Because what it's going to do is it adds more fluid. Think of a glass of tea. Let's say you pour 4 ounces of tea in a glass, and then you put 2 teaspoons of sugar in there, and you stir it and it dissolves. Now, okay, so now your glass has 0.9% sugar. Well, now you add in 8 more ounces of water or tea. Now your tea is 0.35% sugar.
Okay.
Does that make sense to you?
Yeah, it does.
Yeah. So think of it that way. Oh, excuse me. If you have a glass and it's, you're putting something in it, little dots here of sugar, but then you add more water, you're going to add more water to it, then it decreases the percentage of that solid in the water. Okay? So you may have, 0.9% now, or let's say your sodium's high. Let's say your sodium in your blood is 1.5% and now it needs to get down to 0.9. If we add water with very little sodium, then it's going to decrease the percentage of it in there because it's going to increase the volume of water. So what I'm trying to do is give students the tools to think about this critically without having to memorize too much.
Mm-hmm.
If you understand these principles of how, osmosis and how fluid moves around in the body and that salt sucks, then you can kind of think your way through a lot of stuff. So
yeah.
That's how I did it. That's how I learned it. So I hope that helps a little bit. So okay, so let me go back to sharing Google. There we go. All right, fancy, right? Okay. All right, so in this one, fluid and electrolytes are going to, there's going to be a few questions on, those type of things. So this will cause giving hypotonic will cause the fluid shift from the plasma to the, tissues. Yeah, tissues. And you can go through those and try it out. I'll bet you can answer a lot of them now just by talking about that. Fluid overload may result when an IV infusion, that's spelled wrong, is too fast. Rapid or slow. So fluid overload is too much fluid. Put IV fluids in too fast, you're gonna get fluid overload. Okay, so we have about 7 more minutes, so let's just kind of see if there's anything. That's the same question. Geez, we ask you that same question a lot, don't we? About what time of day to give the diuretic. Okay, ACE-induced cough will not be relieved by cough medication. People who are on the ACEs like lisinopril, they tend to they get this kind of nagging tickle cough. And if you hear somebody doing that and they say, oh, I've been doing that a couple months, I think it's allergies or something, you find out if they're on an ACE. You'll probably find out if they are. If you stop the ACE, it goes away.
Okay.
Beta blockers slow the heart rate. Know that. People with implementing lifestyle modifications may eliminate the need for pharmacotherapy in people with hypertension. Yes, that's true. People have hypertension for life. And what happens is if they lose weight and they exercise, they can get off of medications, but it doesn't cure the hypertension. But what we say then is they have hypertension well controlled on lifestyle modifications. We don't say they were cured of the hypertension now because they still have the ability to do that. So we don't take the diagnosis off. We just say now it's controlled with diet and exercise with lifestyle modifications. Anger and stress can cause blood pressure to rise, and this is talking about your receptors. Enalapril, that is an ACE. So just if it's not a prototype, that's okay. You can still read about it, but your prototype should do the same things as any other drug in the class. And I know this is an ACE because of the prill at the end.
Right.
Yeah, so that's how I know. Profound hypotension. Yeah, hypotension. So it'll cause hypotension. So if you're giving a blood pressure medicine to treat blood pressure, the highest risk is that it goes too low, or that they get orthostatic hypotension and don't have the ability to regulate their blood pressure when they stand up. That means that when they stand up, they get their blood pressure, all the blood from the brain goes to their body, and they get dizzy and they can fall. And so they can drop from, what we do is we do these blood pressures. We have them lay down, take their blood pressure, then we have them sit up, and these are called orthostatics. And we have them sit up, we take their blood pressure, wait about 5 minutes, then stand up and take their blood pressure. And I've seen drops from systolic 150 down to even 75 with those different measures. So they do get a significant drop. And in old people, you sometimes just have to do the best you can. So pregnancy category, they cannot take an ACE while they're pregnant. It might be a D. I don't think it's an X. We'll have to look it up though. Let's see.
Okay.
A single letter. I think it's, what do you think?
It's probably D since it's just higher.
Yeah.
We
Okay.
don't.
4 target organs most commonly affected by are the heart, kidneys. So when you have high blood pressure, they're at risk for, what happens when I gotta tell you this, it's the last thing I'm gonna tell you, okay? So if you have, let me get back to my screen, I stopped sharing, and then I'm gonna go to a new whiteboard. When you have somebody that is, I wish I could make this more narrow, pencil, let's see if that works. Okay, so you have a blood vessel here, and then you have your blood inside is exerting pressure onto the walls of your blood vessel. This is the blood vessel here, and this is the blood inside the vessel. And increased pressure in here creates these sort of micro tears. It's like having a water hose. You have a water hose, and you turn the water on. So now there's pressure inside of the hose because it straightens out. You may have a crooked hose and it straightens out. And then sometimes, think about if the pressure gets so high that it creates a leak. And you've seen where you have, a hose that develops a leak, right?
Mm-hmm.
Well, then your platelets in your body are going to go to that area to heal it because you have a boo-boo. Now you have a little tear and you don't get really the leaking. I'm just saying that, so now you have these little platelets and fibrin that are going to go to this area and plug up the hole. So this high blood pressure caused a tear or a break in the lining of the vessel. And now you have a little clot forming. Well, now you have atherosclerosis. That's how you get these plugs in your vessels, and that's why hypertension is a risk for that. Okay, so the reason that I was talking about that was because the question was, let me see, application, and let's just answer that one question. Did it even make any sense? The 4 target organs most commonly affected by hypertension are the heart. The hypertension has caused atherosclerosis in all of these organs. Well, the retina hypertension can cause the vessels to break, and then you can get blindness. It can actually cause cause you to go on to end-stage renal disease, which we know is dialysis, and the brain. All of these mechanisms, you get damage from the hypertension to all of the macro and micro vessels. If you think about the size of the vessel that you're dealing with, let's say that if you have a micro vessel in the brain, and this is a major vessel here, but let's say that you have a micro vessel that's little teeny tiny, and it's going to break and it's going to close up completely, or it's just going to bleed everywhere and damage the tissues around it, and then everything that it was supplying dies, right?
Mhm.
Because that vessel's no longer working. So that's the mechanism of hypertension. So I wish I could have gotten just a little bit further, but I don't want to, continue on and take more time. But be sure,
No,
go ahead.
it was helpful. It was good what we covered.
Oh, good, and I'm glad to hear that. And then you can be sure and watch those tutorials, and those you might find those helpful that the tutor is doing. And then I'm going to publish this review in the tutoring area in the discussion forum. So thank you for all of your good questions, and
Thank you.
and I appreciate you working with me.
Yeah, thank you very much.
Bye bye. Leslie,
Bye.
I see you on there with your hand held up, and it doesn't look like your microphone is working, so you're not connected. But you may be able to hear me. But I'm going to post this in the discussion forum under tutoring.